Dr. Sean Mackey is a Redlich Professor of Anesthesia and of Neurology and Neurological Sciences by courtesy at Stanford University. Dr. Mackey completed his undergraduate and master's degree studies in bioengineering at the University of Pennsylvania and received his PhD in electrical engineering and subsequently his medical degree at University of Arizona. He went on to Stanford where he completed his anesthesia residency and then his fellowship in pain management. He's currently the chief of the Stanford Pain Management Division, the Pain Medicine Fellowship Director, and the Director of the Stanford Systems Neuroscience and Pain Lab. Dr. Mackey's primary research interest involves the use of advanced research techniques such as functional and structural neuroimaging, psychophysics, and neurobehavioral assessment to investigate the neural processing of pain and neuronal plasticity in patients with chronic pain. He's a member of several professional organizations. He's on the board of directors for and future president of the American Academy of Pain Medicine, is a permanent member of the NIH NIDA Study Section, and serves on the editorial board and is a reviewer for multiple scientific journals. So welcome, Dr. Mackey.
Thank you. Thanks, everyone. It is a pleasure to be here. I have been watching this organization grow since its inception when Robbie came to me and asked whether the pain division would help support getting this going. And it's just been thrilling to watch how he, working with all of you, has built this up. And excited to have you all here on a Saturday morning of all places to talk about pain. And I'm excited to be here to talk about my favorite topic, which is in fact pain. And Robbie asked me specifically to talk about this Institute of Medicine report. So if any of you have ever heard me talk before on any of my pain and brain talks or any of my opioid talks, this isn't going to be like those. This is we're not going to have a lot of video clips. It's not going to be as entertaining. This is going to be kind of one of those talks that's going to be good for you, if you will. I'll try to make it as enjoyable as possible. It is really giving you some background on the state of the art of where we're going in the field of pain from a national level. So, and when I'm talking about the Institute of Medicine report here, I should also mention that as a co-author of this, they've got some very clear rules about how I present information related to the IOM report. And as I present this to you, I'm speaking not as a division chief for pain medicine, not as the president-elect for AAPM, but I'm speaking as an IOM committee member. And so I'll be speaking kind of with one voice from that IOM committee. And if you've got questions, I'm going to answer in the context of the IOM committee and keep it to that. So people may not be familiar with what the Institute of Medicine is. It's this nation's main overriding advisory board for answering questions related to medicine. It's part of the National Academy of Sciences that was chartered under President Lincoln back in 1863. It's a nonpartisan, non-profit organization that works outside of the government realm, but also works collaboratively with the government and with other organizations to answer important questions related to health. You guys may remember back in 2010, the Affordable Care Act was passed, and as part of that, there was a charge to the Institute of Medicine to take on this issue of pain and to address a number of key issues related to pain care, pain research, and pain education. And so specifically, we were tasked with the following bullet points. We were supposed to review and quantify the burden of pain in this country, identify barriers to appropriate care and education in the country, identify special demographic groups and populations where we needed to better reach out, determine what the specific scientific tools and techniques are available, and then also investigate opportunities for public-private partnerships. So the IOM reached out and put together a 19-member committee. And I represented pain, and then also I'm the token, I guess, anesthesiologist, which I thought was somewhat humorous in that I haven't done anesthesia in about a decade. I'm more of a recovering anesthesiologist. Most people think I talk more like a psychologist these days than anything else. But I represented, if you will, anesthesiology. Dr. Phil Pizzo, the recently former dean at Stanford University, was one of the chairs of the committee, and we had representation again broadly from the other fields. I'll share with you, if you had to pick one group that had more representation on it than anything else, it was actually psychology. There was a number of pain psychologists on the group. There was Dennis Turk, Bob Kearns, and there were others as well. So we did a number of things. We did a literature review, and then we also recognized that we were clueless about what the burden of pain was in the country, so we commissioned an econometric study to investigate that, and we asked some folks to mine many of the national databases to figure out exactly what the burden of pain is. And then we had a number of public workshops where we invited people to come in, give public commentary, and we heard from almost all the stakeholders that you can imagine in pain, from a number of patients, a number of patient advocacy groups, payers, insurance payers, device companies, pharmaceutical companies. If they were interested in pain, they were there. We also got public input through websites, and we got over 2,000. I thought it was pushing close to 3,000 or so responses towards the end. We went through every single one of the responses. I'm going to show you some of those responses and some of the narrative that we received from patients and specifically people suffering from pain. At the end of this all, we came out with a number of underlying principles that we integrated into the report. First of all, that fundamentally pain is a moral imperative, and that it is a requirement for all of us who care for people to treat it as a moral imperative and to recognize the importance of it and the fact that we actually have to do something about it. That while pain can be a symptom of another condition, and we have known that for hundreds of years, that as it becomes chronic, as it becomes persistent, it can develop into a disease in and of its own right, one that fundamentally alters the peripheral nervous system, central nervous system, endocrine, inflammatory, and immune system. We recognize that particularly for complex situations, that comprehensive treatment is really the one that gives the best outcomes data. We need, within that comprehensive treatment, interdisciplinary approaches. We need team approaches where we're all working together. That one of the other key messages that's really come into vogue over the last probably decade is that many of the chronic pain conditions that we experience all start with an acute pain injury. And therefore, it's probably better to prevent rather than to treat pain. And if we can identify those vulnerable populations that are likely after an injury to go on to develop chronic pain, we may be able to help reduce this epidemic that we are experiencing. When I say epidemic, I'll give you the sound bites and the numbers in just a moment. That, intriguingly, while we do need more basic science knowledge, there's actually an incredible amount of knowledge already out there that works, and that works very well. But we haven't done a great job in disseminating that knowledge, so we need to get that out there to the greater public and our providers. That we recognize the issue of opioids. We were asked, many of the patients, many of the advocacy groups, they all wanted us to take on this issue of opioids. You know, we were and still are at the height of this opioid, if you will, epidemic, this where you open up a newspaper almost every day and you read something about opioids. But the interesting thing is that we were not charged to take on opioids, and we also worried that if we took on opioids, that the whole report, everybody would just focus on the opioid message and lose sight of everything else. And so we addressed the conundrum of opioids, but without getting into specific details. We appreciated there needed to be a better collaborative role, a partnership, if you will, between patients and clinicians, and that there's strong value in public health and community-based approaches. And I'll touch base on that. The tagline that we gave this is recognizing that we needed to evoke or foster a cultural revolution, that we recognize that all people are ultimately at risk for pain, that it is a uniquely individual and subjective experience, that we need a biopsychosocial approach for the treatment of pain. And we struggled with this word, by the way, biopsychosocial. We had a lot of debates about it. All of us in the committee, you know, we understood it, we bought it, you know, we drink the Kool-Aid, if you will. But we also recognize that that term carries with it sometimes some connotations out in the lay public that we worried that it might put people off. And so we were very careful about the wording of this to basically introduce the concepts at the same time not alienate people. Again, that comprehensive interdisciplinary approaches are really the most effective. We needed to break down barriers, including financial and payment. You guys live and breathe with this every day. And again, we needed this cultural transformation to better prevent, assess, educate, research, understand pain. And we also finally offered a blueprint for how to do this. So in diving in and talking about the perspective of the person in pain, I'm going to give you some of the narratives, some of the commentary that patients provided us. And I'm going to interweave it, if you will, throughout this lecture, throughout this talk. And I've broken it down. This first series we call Despair. And this is a patient who wrote into us, the impersonal hostility of the payment system, the intellectual poverty of the research, and the cognitive poverty of my providers combined to turn me from a spirited and capable professional with a good income and bright future into a needy, dependent on the state, dependent of the state, with no profession, no future, and a life that is ever more bleak and limited by pain, weakness, disenchantment, and despair. So you can see that people were incredibly articulate in describing their despair, their frustrations over pain. When we broke down this report, we broke it down into 4 key areas. So we talked about the public health challenge, we talked about the issues of pain care, caring for that patient with that person with pain, education of providers, which I think was one of the biggest areas that we really focused on, and then finally research. So let's talk about another narrative. Yes, I get out of bed in tears and live with pain every day. The simplest things can cause debilitating pain to the point of almost passing out. It hurts when you walk, when you sneeze, when you cough, when you move your bowels. Your life as you knew it is over. If you do not have a bathroom, that pain when urine stays in your bladder is unimaginable. Like broken glass inside you when it is in and when it comes out. My marriage of 40 years is always being tested. We can't travel like we dreamt of. I can't watch my grandchildren. My life and my husband's life is over. I hate myself and my body, and I know this is an awful thing to say, but at least cancer patients are going to die. But I have to live with this until I die of something else.